So I'd now like to invite Dr. Mark Larsen from the Black Dog Institute. Mark holds an early career fellowship from the Society for Mental Health Research and comes from a background of biomedical engineering. He's particularly interested in applying his research expertise in the use of technology, particularly mobile phones, in healthcare applications with a focus on suicide prevention. So today Mark is going to speak to us about the RAFT project, or Reconnecting AFTer Suicide Attempt. It's important to note that EMF is not funding this project. However, our research support manager in Toowoomba, Richard Henshaw, played a pivotal role in getting this youth suicide prevention project off the ground. So in his role with the RSN, Richard helped the Black Dog research team build collaborations with key emergency medicine clinicians and researchers locally, as well as across Queensland. He also helped the team identify new funding opportunities. So it's a perfect example actually of how collaborations are made possible through a research support network such as the one that EMF provides. Welcome, Mark.
Thank you for that introduction, and thank you to the EMF for inviting me today to talk a little bit about the development and piloting of the RAFT intervention. So the background to this project is we know that suicide is a leading cause of death. It's notably the leading cause amongst young Australians aged 15 to 44. So as well as being a leading cause of death, we know that a hospital-treated episode of self-harm is the single strongest risk factor for eventual death by suicide. Hospital-treated self-harm has a repetition rate of about 15%, which is and approximately doubles in those with a history of previous self-harm. So the National Mental Health Commission commissioned some research through the Black Dog Institute to look at patients' experiences of healthcare services following a suicide attempt, as well as the experiences of their family members and carers. And so the text there's a bit small, but part of this report included a data linkage study within New South Wales, which found that 40% of admissions for self-harm received no community mental health follow-up in the month after discharge. And of those people who did receive follow-up, the majority just received a single contact of less than half an hour. So it's a bit of a gap between what we should be providing. The report also looked at possibly effective strategies to reduce repeat presentations for self-harm, and one such technique was using brief contact interventions. These are simple follow-up letters and postcards, which in a meta-analysis have been shown to reduce representations by about a third. Now, this is just from 3 studies which use postcards as the method of contact, and this led us to develop the RAFT intervention, which is trying to adopt a similar approach but using a text message based follow-up contact. So the first stage in our project was to hold some focus groups with people with lived experience of a suicide attempt to find out a bit more about their experiences in hospital, what strategies they found helpful after discharge and what perhaps wasn't so helpful. And we worked with a clinical research design group to iterate through a few versions of our intervention to come up with the current version, which we're currently piloting. And this version is initiated following discharge from the ED. And for the pilot study, we do require consent from patients to receive these messages. And if consent is given, then the following day, they'll start to receive the study messages. The writing's a bit small, so you don't really need to see the detail, but this first message is around coping with distressing feelings in the immediate crisis period and includes a link to suggested activities that our lived experience participants found helpful. Participants then receive an extra 5 weekly messages around other topics identified from the lived experience groups. This is around safety planning, coping with distressing feelings, coping with thoughts of suicide, reconnecting with others around them, and a brief intervention for alcohol use. And after those weekly messages, we then swap over to monthly, more general supportive messages for up to 12 months. Again, the writing's a bit small, but there's also a means of getting access to the local crisis contact details if participants reply to one of our messages. And in our current pilot study, we're including some follow-up self-report data collection about repeat episodes of self-harm and suicidal ideation after 6 weeks, 6 months, and 12 months. So we're currently running this pilot across 3 emergency departments, at the Royal Prince Alfred in Sydney, at Toowoomba with the help of Richard Henshaw and Michelle Kerr, and more recently at the Royal Brisbane and Women's Hospital with Clancy MacDonald and Nathan Brown. And to date, we've managed to recruit 7 participants, which Wikipedia tells me is slightly better odds than the state of origin and state breakdown. Unfortunately, the 7 people slightly below our expected recruitment targets, and this has been due to initially adopting quite a conservative recruitment approach, just focusing on the point of discharge. And we quickly found out that that's actually quite a challenging time to be approaching people, so we've broadened out to try a few different recruitment strategies, and this has helped to pick up the numbers. So with the 7 participants, it's a bit early to really draw conclusions from the data, but we are encouraged that participants do seem to be linking through to the online material shown here with the tick boxes, and this is the first time I've used this visualization, so any feedback on whether it's comprehensible or not would be welcome. What we're particularly encouraged by is people seem to be accessing the material earlier on in the first couple of weeks, and this is really the initial crisis period. Although people are also just engaging with some of the later content, which is perhaps suggesting people to selectively dip into what's more relevant for them. And we're also encouraged that from our online material, people are linking through to external resources on coping strategies and safety planning. So again, with 7 participants, it's a bit early to say anything, but there does seem to be a decrease in suicidal ideation over that 6 weeks, just in a simple pre-post comparison. So our next steps for the project, we're hoping to hit our recruitment target, aiming for 20 to 30 participants in this pilot stage, after which we're hoping to conduct a full RCT with an economic analysis to look at whether this is both an effective intervention and a cost-effective intervention for reducing repeat presentations for self-harm. So finally, again, I'd like to thank the EMF and to thank some of the other funding organisations which have supported this study so far. Thank you.